I so appreciate you all joining us today for this sort of important topic. I know Jenny and I think it's very important, and we're happy that everyone else does too. So we came up with this topic just because it comes up a lot every day in the work that she and I do with individuals and family members. But also I think that there's a lot of myths around the community regarding eating disorders, sort of the etiology of all of them, misconceptions around who gets them. And I think a lot of these sort of myths are perpetuated via various media platforms. So I think it's important for us to talk about it today. And I also am hopeful that you folks will kind of understand by the end of this why the myth that eating disorders are a choice is so harmful. So just want to get started quickly, as I know we have some time constraints. So as far as questions go, if you want to enter any of them into the conversation bar here, we'll do our best to get to them. It's likely not going to be during this presentation, but hopefully we can reach out to you via email to answer those questions. So hi, Jenny. Thanks so much for joining us.
Well, it's my utmost pleasure. Always great to see you, Natalie.
So to start, we're going to try to make this as conversational as possible, but let's just start. I know probably many people aren't super familiar with eating disorders, so let's just start with something kind of easy. How does disordered eating sort of develop? Like where do they come from?
Well, if only if that were a simple answer. I like to call it the perfect storm for lots of different reasons. The word perfect will come up later. I think it's important for us to first look at a few definitions, right? So what do we know? There's something called anorexia nervosa. There's something called bulimia, binge eating disorder. And then there are some other categories that we'll talk about also. Probably just to make sure we all have a baseline foundational understanding. Anorexia has to do with an intense desire for thinness, beyond the point that would be physically healthy. In fact, it puts people at great risk physically as well as emotionally. And you can go about that either by restricting or not eating. And the other way to go about that, of course, is to just eat in very, very, very small amounts or eat nothing. There's also a purge type of anorexia, which is less common, but the small amount someone does eat, they just cannot keep in their system. Bulimia also obviously has a purge aspect to it, but it's preceded by what we call a binge. And I'll come back to what the definition of binge is in a minute. It's not what people normally think. And with bulimia and binging and purging, there's usually a lot of medical issues as well, because it affects the gastrointestinal system, the esophagus. A lot of blood levels are quite abnormal because it's not natural for the body to get rid of food. It's more natural for it to take it in as fuel. Binge eating disorder, which
Jenny, really quickly, I think maybe it's important to distinguish between what a purge can look like, because I think a lot of people might think that a purge is just kind of self-induced vomit, but it can look a lot of different ways.
Great question.
Right?
Yeah. So purging is not just self-induced vomiting. It also can be done with laxatives. It can be done with diuretics. I hope we're not giving anybody tips here. It can also be done with exercise. And, that's a lot harder to pinpoint because it's very subjective. I think what tells us if that's happening is really context. If, for instance, someone just loves to work out, that's one thing. If they're doing it in a very purposefully compensatory way, I ate that, I must not only exercise that, but I have to exercise beyond that. That's a way of purging. It too has its health risks. Thanks for asking. And then, of course, there's binge eating disorder, which I think is probably the most misunderstood of the three. And that has to do, and I'll give you just very quickly some, I think, useful distinctions within binge eating disorder. Let's say that one has, something that they're nervous about, upset about, grieving about, whatever their emotional state may be, and they knowingly say, you know what, I just have to numb this out. I'm going to have this food. That's what we would call emotional eating. It's very situational, it's very purposeful. If you're someone, let's say, who sort of just grazes all day long, having nothing to do with hunger cues, satiety cues, just kind of eating all the time in a fairly unconscious way, mostly, or you eat, very, very large portions, we'll call that compulsive overeating. True binge eating has components of both of those, but it's also vast amounts of food, much, much, much more than you would normally have, that your body could normally withstand in one sitting. It's usually, although not exclusively, at night. It's usually, when someone is alone, though not exclusively, but that's most of the time. And it usually only ends either because someone's in physical pain, or because they fell asleep, or because they ran out of food. And it's much more profuse than the other two distinctions. So that just sets our playing field for what those three major distinctions are. There are others, like you may have heard of ARFIDs, which is mostly, children, it starts in childhood. It's like what we call severe picky eating. There's also others that don't quite fall into those categories, like night eating. But I think that gives us, mostly the story. So now to get back to your original question, how do eating disorders start? How does all that come about? Well, if there are 1,000 patients you're looking at, there'll be 1,000 different stories about what was the thing. And usually at some point they can pinpoint a thing, something someone said to them, something they heard, something they saw, some decision that they made. But there's much, much more to it. We like to look at what we call the biopsychosocial model. So we're looking at the biologically. Is someone more prone to an eating disorder? On paper, yes. That's not to say it's your fate, but certainly one can be more prone if, for instance, there are addictive behaviors in the bloodlines, perhaps drug abuse or alcohol abuse or anything like that. You can also be at greater risk if there are others in your bloodlines who have actually had eating disorders. You're also at greater risk if you need ways to cope with any one of a million mood states, whether it be anxiety, be it depression. Another big factor is if you have what we call obsessive compulsive tendencies. Everybody says OCD, like, oh yes, I clean my drawers all the time, I'm OCD. Yeah, there is that, but this is more about the kind of OCD that is debilitating. People who cannot leave their home until they turn off the stove 20 times. People who cannot be around, you can imagine now during a pandemic that really plays itself out in terms if you have, germ phobias. So again, OCD is also one of the things that sets people up for that. There's also social factors. You can probably recite this with me, right? The effects of social media, the media, world events, certainly diet culture. Diet culture is such a big factor. It's so ingrained in our lives that sometimes we don't even realize how pervasive it is, except that it sets up expectations that we should somehow be able to compete with whatever the norms are within diet culture. There's also one other factor that I like to consider, which is spirituality. Not everyone needs to have any spiritual influence in their lives, but what we tend to find, what the research shows, is that those who suffer with bona fide eating disorders tend to have what they describe as a spiritual void, some lack of faith, be it in themselves, in others, in whatever is their spirituality of choice. So those are just some of the factors.
There's this
Trauma.
really I'm so sorry, but to interrupt, but there's this really interesting quote that I always remember from Walter Kay, and it's something like, genetics load the gun and environment pulls the trigger. And I just think that that's so profound and so true in a lot of the cases that we work with.
I'm so glad you said that. I can't agree with that more. I mean, it's a nature-nurture debate, but I think it's always both. And to that end, I mean, that's sort of the study of epigenetics, right? Epigenetics says, simply, if I have it right, that there may be tendencies that we have that may or may not ignite themselves depending on the proper triggers. There are some that would say that's also true of cancer, but that's out of my field of expertise. Trauma is, I think, the single greatest factor in all eating disorders, and dare I say, also in addictive behaviors, also, be it, whatever the substance may be. Think about what trauma does. I mean, also imagine the age of trauma, right? There could be multiple trauma, and trauma is whatever you define, right? Many people use this expression, little t, big T. Okay, if that's useful, it's fine. I think trauma is really based on perception, experience. It's circumstances where you felt like you had no say, no control, whether that be blatant abuse, whether it be severe poverty, whether it be, whatever the form of trauma may be, certainly, terrorism. There are people who, rightly so, will tell you that this pandemic is traumatic to them, to their experience, and I guess it depends on age as well. I think we're going to, my humble prediction is that over the next 5 to 10 years, we're going to see a rash of traumatic responses to what we're all going through right now. Trauma plays itself. I'm sorry.
And as that sort of relates to eating disorders trauma, we kind of can view sometimes eating disorders and the behaviors associated with these eating disorders to be kind of coping skills for these traumatic events that have happened. They can be used in various capacities, like to numb or to avoid, those types of things.
Yeah, and that kind of brings us closer to our original question, right? Which is, are eating disorders a choice? We'll let you decide that by the end of this webinar. But, I think the reactions we have to trauma are really not something where we sit on the edge of our bed and say, let me see, how can I respond? It doesn't quite work that way. It really is very automatic in its own way. It's about survival. Human beings have a need to survive. And so we will do whatever we need to do to survive. So if it means something happened to me and I felt completely out of control, well, okay, it turns out if I have an eating disorder, there are certain things I think will put me in control. I can't control my life circumstances. I can't control what's happening in the world. I can't control what's happening around me. But for God's sake, I can surely control in some way how I soothe myself by either eating or not eating. But that comes after the fact. That's in retrospect. When you're looking, when you have the courage to go through the investigative process to see, it's not like you knew it in the moment, but in retrospect, you can say, well, of course it makes sense that I was going to do something like that in order just to self-soothe. And I think self-soothing is so much at the heart of all disordered eating. I think the takeaway here is that it isn't simple. It isn't any one thing. If I had a nickel for every loving, well-intentioned parent, loving, well-intentioned partner, friend, who said, if you would just eat, if you would just not eat, if you would just stop that, how simple your life could be. It's not that simple by any means, I would say,
Sure. So let's kind of go into our next question that I think might be helpful for folks to hear. Who tends to be impacted by disordered eating? And I think also important to know is who we see being impacted in the media and how that sort of differs from who you and I, as professionals in the field, might see coming into our office and into our therapy seats.
So when I humbly entered this field, years ago, what I saw was that it was considered the rich white girl's disease, and that ain't so. Now, eating disorders are identified globally in 40 countries at least, and I think there are more. It is certainly across genders, across age categories. What we're finding in the field is that they're starting earlier and they're lasting longer. I think most of us who are treating folks are treating anywhere from, unfortunately, age 7 or 8 to well into 60s, 70s, if not later. So that range has changed. Now, who's vulnerable? Well, okay. I think it has to do with, again, what set of inherent coping skills does someone have to deal with any of the things that we were talking about. Age is a factor. Eating disorders are the third most common illness in, for instance, adolescent females, just to use one category. And there's always concomitant anxiety or depression. It's never just disordered eating. I think, as we say, ethnicity plays a role, right? In what culture isn't food somehow an expression of the culture, of love, of family, of communing? And so that's either good news or bad news, depending on each person's experience. As we are so much more, thankfully, aware of the trans community, right? You can imagine that, there's a hard enough time being in a body that doesn't fit their gender assignment, and then trying to cope with that body, coming to the courageous decision, no, actually, this is not how I identify, going about all that may be required to identify with the gender that they feel more comfortable in, and then also now dealing with the world's reaction to that, whether it's their micro world or the macro world. So that's a very, very, very vulnerable population.
I think also too, Jenny, there's this great study by the Trevor Project and the National Eating Disorders Association of adolescents who identify as transgender and non-binary that people should definitely check out. We can put the link in the box later today, but it's pretty striking, the correlation between trans and non-binary population and those who develop eating disorders.
For sure. Here's a group that I think might shock some of you, but twins who are, let's say identical, less so in fraternal, although it's there. And I'm sure you can imagine why. That's a little of nature and nurture, isn't it, right? So on the physical end of it, you have, sort of, pardon my biology here, but you have like two embryos that are sharing, nurturance while in the mother's womb. And so that either goes well or it doesn't. And so there's some genetic predisposition to struggle in some ways in that regard. God bless you. The other reason that twins are more at risk is because, obviously they want to have their own identities. And I know that most parents go out of their way to try to do the right thing where that's concerned, but there is inevitable there's a bond, but there's also inevitable competition at the same time. And so there are so many studies now that are seeing that in sets of twins, and more so female than male, but not exclusively female, about 50% of the time, both twins will get affected at different times on the timeline. 50% of the time, only one will get affected. The other risk category group that I think we can't leave out is athletes. be that school related, be it professional athletes. Here's a little trivia question. Which sport do you think has the highest occurrence of eating disorders? I wish we had Jeopardy music now. Okay, so I'm sure you're thinking, you know, perhaps gymnastics. I'm sure you're thinking, you know, anything that has sort of weight.
Wrestling. That's good.
Wrestling, right? But guess which one is
Running.
top of the list? Are you ready? Jockeys. And jockeys get weighed within such a small margin in order to be able to ride the horse, that there's and not only is there a high incidence, it's actually encouraged. They're encouraged to purge, they are encouraged to restrict, and so you can imagine, you know, what that's like. And lastly, I would say, you know, people who suffer from food insecurity, they really, it plays itself out, you know, for years and years. And especially those who have suffered food insecurity, there tends to be more of a binge behavior and then a binge purge behavior. I would be remiss if I didn't say at this point that probably more than 80% of all people who suffer any form of disordered eating travel the entire continuum. They go from one end to the other. They can certainly start out, you know, anorexic or in their behaviors, and they realize after some period of time, oh my God, this is freaking everybody out. In order to get everybody's attention off of me, I'm gonna have to eat. But by the way, I can't tolerate that food in me, so I know what I'll do. I'll purge instead. So then they won't be on to me that I'm restricting. But by the way, I still don't like how I feel in my body. So then now I think I'm gonna, you know, make an uptick in my exercise. And at some point, purging becomes very uncomfortable physically, hard to hide, hard to live with. And so all of that stops and the binging is left behind. And diet culture plays a severe role in all of this because it's designed to have you, you know, want to restrict for a certain period of time, reach some goal that's going to somehow make you a better person, and then you go back to what you call real life. So it's a deprivation cycle. You know, I encourage all of you who are listening to or watching to try to read a book which is called Body Respect. It is really all about this notion of health at every size. And I will warn you in advance that when you first start to read it, you'll say, oh, this is hogwash. This doesn't make sense. And I promise you that it does. Because whatever we think is the ideal of what a body is supposed to look like, or whatever the ideal, the values we assign to, oh, that's right, people in that body size are disciplined, people in that body size are sloths. However we tend to look at those things, they are historically driven, they are societally driven, and one of the ways in which people really start to make a recovery from all of this is to absolutely accept, in the biggest way, their humanity and who they are as people, rather than what their dress size is or their clothing size.
And I think also, Jenny, too, as far as sort of who is impacted by disordered eating and sort of the myths that are perpetuated in our culture is, I think it's important for us all to be aware that you can't see an eating disorder. So you can't judge, you can't say, oh, that person's thin, they definitely have anorexia, or that person's in a normal sized body, so they don't have anorexia, or they don't have bulimia.
Right.
Eating disorders come in all shapes and sizes. And I think if there's one takeaway you can get from this, I think that's one of the most important ones, and also kind of segues us into this last kind of question that we're trying to answer for everyone is, are eating disorders a choice?
Well, I'm going to leave that to everyone to decide. I humbly say no. You know, there are even moments when families or loved ones or even, you know, treating teams might say, well, you know, he or she or they are just, they want this. It's comfortable. No, it's never comfortable. There's this very fancy expression we have, which is ego dystonic and ego syntonic. And very simply what it means is someone comes in to get evaluated and they sit in front of you and they say, well, my parents asked me to come in and I don't really think there's any big deal here. I don't know what the big deal is and all that. That is a very difficult person to treat. Anybody can be treated, but it's a very difficult person because for them, what they're doing seems perfectly in line, no problem. That is what we call ego syntonic. Ego dystonic is when someone comes in and says, I realize what this is doing to me, my family, perhaps my finances, perhaps my professional standing, perhaps my chances of getting into school, whatever it may be. I know it's hurting me. I don't like it, and I can't do anything but what I do. I can't help but do these very behaviors, which I know aren't working. And there are days that I can really see that I really shouldn't do them, but I'm powerless to do anything about it. That is ego dystonic. It's not okay with them, but they don't think there's any other choice. And so the focus of work really becomes identifying triggers, past and present, also coming up with a host of different coping skills and trying to figure out what all the pieces of the puzzle are. How much of this is trauma? How much of it is mood related? How much of it is, the culture within their own family? Families always mean well, but there's a culture within your own family. And one of the things that, is often so helpful is when we have either, dietitians or psychotherapists who actually go into the home and have meals with families, just to sort of set a different pace. And in the beginning, it seems a little contrived, but I think over a short period of time, it becomes a very valuable experience. So my contention would be they're never a choice. Ironically, most eating disorders, if not all, as we said in the beginning, start because there's this inherent loss of control. That's the perception. The irony here is that this does not give you control. You don't have it, it has.
That's it, actually.
Yeah.
So I think also too, it's important to remember that there are choices that are made along the way, right? So like from the start of your eating disorder journey to however long it goes, there are choices that are made along the way. Certainly you can choose to, and a lot of these choices are made really kind of, not without even thinking. Maybe they've chosen to, cut out a certain group because they think it's going to be healthier. So that's a choice, but then it kind of snowballs, right? Especially we talk about the biopsychosocial model. If I have some of those perfect storm features from each of those biological, psychological, and social pieces and compartments, I am at higher risk to developing them. And it's harder for me to then choose not to continue the development of eating disorder, right?
For sure. What comes to mind as a clear illustration of all of this is, and I'm sure nobody on this call knows what I'm talking about, that Monday morning diet mentality? Okay, this is it. This is the day.
Starting fresh.
I'm going to be a better person. Here I go. And notice that, first of all, that's not the way to be a better person for yourself. And secondly, notice that despite whatever you think the motivation is in that moment, be it real or imagined, be it healthy or unhealthy, none of that is sustainable. And so again, it's not sustainable because there are choices that were taken away from you that shouldn't have been taken away from you. And now there are other choices that you make, and we're calling them choices, but they're really not. They're more compulsions. They're more just a desperate way to cope, I think.
Sure.
Yeah.
So I know that this was really quick, and there's probably so many more questions that kind of evolved from this. We're hoping that hopefully this will sort of move into something that's more regular as far as eating disorder topics go, because it's obviously a very complicated and complex diagnosis. So feel free to let us know if there's specific topics that you want us to kind of talk about next time. I do see some questions about night eating and athletes. So all those are wonderful topics that we can certainly move toward getting a webinar, a separate webinar.
And I am happy to answer any questions offline, any that you either email us or type us in the chat box. And I'm most certain that we'll do some future webinars on deeper levels of this, and perhaps for a longer period of time if we can.
Orthorexia, I see too. Yeah, that's a great topic.
You bet.
Well, thank you everyone so much, and certainly you can reach out to us or Sydney, who started all of this, if you have any further questions, and do let us know if you have future topic ideas.
Everyone, please stay well and safe.
Yes.
And who knows, maybe one day we'll do this in person. Who knows? You never know.
Someday.
Take care.
Everyone.
Thank you all.
Bye.